Hey everyone, welcome back to the Barbell Medicine YouTube channel, where we bring modern medicine to strength and conditioning and strength and conditioning to modern medicine. I'm your host, Dr. Jordan Feigenbaum, and this is training vlog number 33. I'm getting ready for this powerlifting meet that's a little over a week away. We've got some questions that you guys have submitted and a bunch of form checks on both my own lifts and then some lifts that you have submitted as well. So let's not waste any time. Let's get right into the questions. First question is from Perry Tate, and it is on static stretching. So I decided to call up Dr. Michael Ray, get his input on this because he wrote a great article over on a website called Mobility Explained. So let's see what Dr. Ray has to say. All right, so we've got Dr. Michael Ray on the line right now. And so we've got a question here on the Barbell Medicine vlog from Perry Tate. The question is, what demographic would benefit from static stretching? When, why, and how should they stretch? I know stretching doesn't prevent or treat pain and injury, and I know it's not the most specific way to get better at the squat or deadlift, since most form difficulties are a result of improper coaching rather than poor mobility. Might come back to that one. But I'm still curious to know when it might be useful. So, Dr. Michael Ray, what do you think about static stretching?
Yeah, this is an interesting discussion. It's typically defined as a muscle taken to end range while lengthened and then held there for some period of time as static stretching. And I wrote a really lengthy piece called Mobility Explained last year that really dives down the rabbit hole with this topic. I can't say that I recommend it to any population currently, whether we're talking clinically or if we're talking for just general training for athletes. And that's not just barbell or resistance-focused athletes. That's also sport-specific, like team-based sports, soccer, rugby, stuff like that. It doesn't seem to have any meaningful long-term effect for the populations that engage it, and based on the research that we currently have on it. So it's difficult. I don't think I would recommend it for anyone at this time. I mean, that certainly could change in the future. But the way I look at this is it's kind of return on investment. So the cost of investment would be my time, effort, and potentially money if I'm paying someone else to statically stretch me. And then what's the return on that? And right now, the return just doesn't seem meaningful enough to put time into it. It doesn't improve performance. And in fact, if we're specifically just talking about static stretching, we have evidence that it decreases performance for strength and power focused athletes, as well as speed and agility athletes. And so that, I wouldn't do it because we're going to have a net negative out of that for those athletes specifically. It doesn't reduce the risk for injury.
Yeah, interestingly, some data actually shows that it increases the risk for injury.
Yeah, and so those are the two big ones. And then the third one, people are like, oh, well, DOMS. And it turns out we actually have a Cochrane review on that. And it's no positive benefit for delayed onset muscle soreness in a meaningful way. So, and then that's kind of what Mobility Explained, that blog goes through. It's like, it just knocks down all the common narratives based on what we're seeing in the evidence. So I can't think of a reason to recommend it at this time. Usually where this goes back to is people ask me all the time, well, what about yoga? And my kind of thought process is, if it gets you doing something is better than nothing. So I'd much rather see you be active through doing yoga and some of maybe the positive kind of cognitive and mental sides of that and engaging in that process. And I would be much more inclined to be like, well, if that gets you doing something, then I'm okay with that. And oftentimes yoga is not just statically held positions at end range, like people think with static training. A lot of times it's isometric as well, holding a position like Warrior 2 or something, So I'm much more okay with that camp than versus like, oh, you have low back pain because you have quote unquote tight hamstrings and we just need to stretch them, or a tight psoas. That's a really, really bad narrative that can instill some not so great behaviors long term.
Question number 2 is actually on testicular cancer. And so we're going to cover some of the nuances of that particular condition and then expand it towards training considerations for cancer patients in general. So let's start off with a question. This is from Steven. He says, I was recently diagnosed with testicular cancer at 24 years old and went through an orchiectomy of one of my testicles this past week. I was wondering what the long-term effects of this may cause for my strength pursuit with only one testicle going forward. Is this going to limit my ability to gain and maintain muscle/strength at all? Should I look into TRT treatments? Any feedback would be much appreciated. This is a great place to actually say that none of this constitutes medical advice. This is all for infotainment purposes. You should definitely follow up with your doctor with respect to management, treatment, an evaluation of any medical condition. So this is more of a discussion in a general sense. So again, I'm not your doctor. This does not constitute medical advice. Please follow up with your own provider. So with that in mind, let's talk about this in a more general sense. So an orchiectomy is a surgical procedure to actually remove one or both testicles. One is called a unilateral orchiectomy, and then if both are removed, that's a bilateral orchiectomy. Interestingly, this is the initial treatment for most testicular cancers, and then also tends to be diagnostic in that you get to send the tissue off for pathology and then further evaluate the patient for staging. In any event, the survival rate's pretty good. 5-year survival rate's greater than 95%. We're pretty good at treating this sort of stuff. So after the orchiectomy, we have some good news and some bad news. The good news is most of these cancers are curable. In fact, the 5-year survival rate's greater than 95%. The bad news is that your risk of having low testosterone is significantly increased with a unilateral orchiectomy where we remove one testicle. And the risk of low testosterone is even higher for those undergoing bilateral orchiectomy where both testicles are removed because you're removing the specialized tissue that produces testosterone, the Leydig cells in the testes. Dr. Gilligan of the American Society of Clinical Endocrinology says we can cure about 19 out of 20 cases of testicular cancer, but a significant number of testicular cancer survivors have low testosterone, and that can affect other aspects of health. So we look at a study on 1,200 men who all had testicular cancer, had a unilateral orchiectomy, and you compare them to 200 matched controls, age-matched controls. And you look at the sort of risk of male hypogonadism. It was increased by almost fourfold in those who had the unilateral orchiectomy, and the risk was increased with the intensity of treatment. So increased amounts of chemotherapy, radiation, or additional surgical procedures all can confer increased risk. So the question then becomes, what do you do with this information? And this is really similar to the recommendation we give towards the general population. If you have physical signs of male hypogonadism, they should be assessed properly via appropriate testing and additional medical history gathering. So these symptoms would include decreased vigor and libido, depressed mood, decreased muscle mass, and body hair are actually less common. It takes much longer time for those things to manifest. And there are additional signs and symptoms that your doctor will work you up for. These are all non-specific symptoms, meaning that they don't always correlate to low testosterone. And so what you would do if you have these symptoms is just talk to your doctor about them and you would be evaluated appropriately. Now, if you have a patient who's recently undergone a unilateral orchiectomy, then you might be a little bit more vigilant about, hey, I need to monitor this a little bit more closely compared to somebody who hadn't had that procedure. For more information on male hypogonadism, I've actually linked an article from Dr. Baraki in the description below, so you guys can check that out. So shifting away from specifically testicular cancer to the more general question of cancer and exercise, what do? There's an interesting trend for people with cancer actually decreasing their physical activity. So 75% of individuals report decreasing their physical activity levels after the diagnosis, whereas only 4% report increasing their physical activity after the diagnosis. So the main predictors of people decreasing their physical activity after a cancer diagnosis are undergoing chemotherapy, being diagnosed with metastatic disease, or having to undergo surgery. And similar to other diseases, it's very important for those with cancer to actually maintain or increase their physical activity levels to meet these sort of minimum requirements. When we look at mortality in cancer and physical signs that predict a poor outcome, weight loss history, loss of muscle mass, loss of muscle size. So looking at a study on about 1,500 individuals with either GI or lung cancer, if individuals had all three of these poor prognostic variables, they survived for about 8.4 months, regardless of their BMI. So that means it doesn't matter if they were obese, if they were overweight, normal weight, or underweight. And if they had none of those features, their average survival was about 28.5 months. And I think a lot of that comes back to having increased anabolic resistance. So when you think about anabolic resistance, that just means a subnormal response to anabolic stimuli, dietary protein, for example, training, for example, or the hormonal milieu, so testosterone and other anabolic hormones. So when you think about individuals with cancer who are undergoing treatment, they have a lot of things that are actually promoting anabolic resistance, like chemotherapy, which causes inflammation, mitochondrial dysfunction, fatigue, weight loss. Radiation therapy has systemic effects, again, making people tired, weight loss, etc. And they might also be on medications like that deprive them of androgens, so reducing hormonal concentrations in the case of like this bilateral orchiectomy, for example, or other conditions. Or they might be taking glucocorticoids, which also promote anabolic resistance. On the other side of this, we have tools that we can promote anabolic sensitivity. So the first sort of arrow in our quiver would be resistance training. There's a dose-response relationship between the amount of training that you can get somebody to do and their improvement in strength, in lean body mass, in skeletal muscle index, all of these things. One of the problems with recommending exercise in cancer patients who do tend to be older is that it's underdosed. And when we look at this Choosing Wisely initiative, which is from the American Board of Internal Medicine, and in this particular case, supported by the American Physical Therapy Association, they specifically say do not underdose strength training programs for older adults and instead match the frequency, intensity, and duration of the exercise to an individual's abilities and goals. What we'd like to do, again, is to increase the amount of resistance training, increase the amount of total physical activity that these people are doing to start combating some of that anabolic resistance. The second strategy we have, or the second arrow in our quiver, is to engage in a dietary change that would overcome some of this anabolic resistance. So right now, the RDA for protein intake in the United States is 0.8 grams of protein per kilogram body weight per day. However, this fails to account for anabolic resistance and protein quality. In contrast to the RDA, the European Society for Clinical Nutrition and Metabolism actually published different guidelines for healthy aging in adults and also specifically makes mention of cancer patients. And so their recommended protein intake is 1.2 to 2.0 grams per kilogram body weight per day, which is almost double that of the RDA. The idea is that the amount of essential amino acids that are concentrated in a meal, and that includes the branched chain amino acids, specifically leucine. Okay, the idea is that you'd want enough of those per meal in order to overcome this anabolic resistance so that you can maintain or even improve muscle mass and skeletal muscle index and skeletal muscle function and prevent some of that weight loss associated with cancer treatment. So again, that's 1.2 to 2.0 grams per kilogram body weight per day, which breaks down to 0.4 to 0.66 grams of protein per kilogram body weight per meal. And so the benefits of engaging in this resistance training and increase in dietary protein obviously increase lean body mass, increase muscle strength, increase muscle function in cancer patients. You get a reduction in cancer-related fatigue, improvement in their quality of life. You also get increased rates of chemotherapy completion, meaning that individuals who are undergoing the physical activity changes and the dietary changes are actually able to complete all of their chemotherapy course, which is obviously beneficial for their cancer outcomes. And then finally, there's a reduced risk of cancer-specific and all-cause mortality for individuals who are engaging in these physical activity guidelines. So what are the recommendations? The 2018 Physical Activity Guidelines for Americans suggest that on 2 to 3 days per week, adults should perform resistance exercises of moderate or greater intensity for each of the major muscle groups. They also suggest that individuals obtain 150 to 300 minutes of moderate intensity aerobic training or 75 to 150 minutes of vigorous intensity aerobic training. And for a more thorough discussion on that, we would recommend that you read our free beginner prescription text. We talk about that extensively in there. This recommendation is also supported by the National Comprehensive Cancer Network. That all being said, there are some special populations that we should make specific considerations for when we're talking about exercise programming. So for instance, there are treatment-related complications such as lymphedema. It's basically swelling that occurs in an arm or leg, or sometimes both arms, both legs, usually due to removal or damage to the lymph nodes as part of cancer treatment. That being said, we do have data suggesting that high-intensity resistance training is safe in this population. That doesn't mean we should ignore that somebody has lymphedema, but rather we can encourage them to exercise and then manage the actual training based on the symptoms that they have during the exercise. There's also a concern for fracture in cancers that either invade the bone from a primary tumor or from a metastatic cancer. However, early evidence suggests that resistance training is safe in metastatic prostate cancer. And there's established safety and efficacy of high-intensity resistance training in other conditions where there's bone loss, such as osteoporosis. That being said, we probably shouldn't ignore that somebody has this condition, but rather be cautious and monitor symptoms over time, adjust training as needed. And there are a whole host of other side effects that may be caused by cancer treatment. For instance, peripheral neuropathy, which is basically an issue in the nerves carrying the signals from the brain or spinal cord to the muscles. They can become damaged due to the medications. This is called chemo-induced peripheral neuropathy. That being said, there's actually evidence suggesting that exercise may reduce these sort of peripheral neuropathy symptoms. And despite the sort of widespread belief that physical activity is not safe for those with peripheral neuropathy, there's substantial evidence, particularly from diabetic patients, suggesting suggesting that exercise is not only safe, meaning that they don't have an increased risk of injury, but actually is, again, beneficial to those with peripheral neuropathy. This is definitely not an exhaustive list of all potential side effects that people can have from cancer-related treatments. That being said, the underlying premise here is that there's a known benefit of meeting these physical activity guidelines or exceeding them in this population. And so combine that with the known risk of being sedentary, and it appears that the risks probably outweigh the benefits, although again, each case is going to be different, and we would recommend that you have this conversation with your physician. Overall though, we should be encouraging increased physical activity and dietary changes in this population. All right, so we talked about stretching, we talked about cancer and exercise. Now let's go to some of these form checks and see what we can do. All right, so we'll start up here with cold G. This is 370 for 5. Camera angle is weird because it's above your hip, so it's hard to tell depth. It looks close. I wouldn't probably argue with you about that. It does look like you're shifting your butt back out of the bottom, yeah, rather than straight up. It's like you're scooting your butt back. Your feet are staying flat on the floor, so that's good. But I can see your knees are also caving in from here, and I think it's because your stance is so wide, it's hard to keep your knees out. So I would probably narrow your stance just a little bit, and instead of thinking hip drive, like hips go back, I would think leg drive, hips go straight up. You could also think about keeping your knees forward out of the bottom. That was a little bit better, but. All right, this next video is from Andy. Those are my old shoes. I sold them my old Reebok Legacies. This is 405 for 3. Let's see. Yeah, on your toes a little bit on that one. Depth is good though. Yeah, still on your toes a little bit. I can see just because your heels are coming up just a smidgen. Yeah, same one on that one, even though you cut that out of the video. So I'll try to get off your toes when you're squatting. Unknown weight. This is Madeline. High bar squat. Your elbows are way high, just right off the bat. Doesn't make you a bad person, but I would just bring your elbows down. Yeah, tuck your elbows down the side. Yeah, these are like well below parallel. You know, if you want to squat that deep, that's fine by me. But these aren't, yeah, they're not bad. I would just adjust your elbows. Yeah. Sebastian, 391 freedom units for set of 5. Yeah, your heels are coming up off the ground at the bottom. I like those socks though, 3 stripes. Yeah, so it's, what I would do is try to get off your toes, and you're shoving your butt back as a response. So I would probably try to push your knees further forward and keep them there at the bottom. Yeah, see how you're shoving your butt back and it's kind of, you're getting that good morning-esque thing? I know that because I've done that a bunch. But yeah, I see daylight underneath your heels under each rep. Doesn't make you a bad person, but. All right, this is Kristen. I think it's 195. I wish I could see all of your foot. And the silhouette's kind of difficult to judge here, but it is what it is. Yeah, the depth looks right. I mean, it's right on there. I actually don't think it's bad. I just think that the silhouette is tough to tell. Yeah, you see how, again, shifting back out of the bottom. I would aim to try to keep your knees in place coming out of the bottom and push your hips forward on the way up rather than thinking about, yeah, that was, see, there you go, hips go forward. That was a little better on the last rep. Okay, pause squats. This is 345 by set of 4. This is a good angle, good diagnostic coaching angle here. Yeah, the pause is pretty good. It's right at parallel, which I'm not concerned about. I think you're okay. I look at your feet. Yeah, the pause is good. It's just right at parallel. Your feet are good. Back angle's good. I can't see your elbows from here, but that one was deeper. Yeah. And it's like you're sinking a little bit. You're just sinking a little bit at the bottom, like while it's moving. Yeah. So I would, you know, those are fine. Those are fine for a set of 4. I call that RP 7 or 8. All right, this is Manny, 155, I think that's what this is for 5. Yeah, I wish I could have seen you pull your shoulder blades back before each rep, because it looks like you're protracted, and I would just try to have you pull your shoulder blades back, push your chest up into the bar. Yeah, that's the only thing I'm seeing right now. We don't have much leg drive here. Yeah, it's not bad. It's not bad. You hit the rack, I think, on the way up too there. So it's hard to kind of do this with the self handoff and everything, but I would have you scoot down away from the pins a little bit where you can still unrack it, but you're not gonna hit the pins. Yeah, a little bridge there. And then pull your shoulder blades back and take a big breath for each rep. Not a bad set though. It's 375 for 3, sumo. We're doing the devil's work. It's not bad. I see your knees caving in a little bit off the floor, and if you can keep them out, I mean, it's just minor. It's just real light. So, not a bad set. 355 before. This is Jason. Looks like 335 from here, unless there's a 10 somewhere else or a 55-pound plate. Yeah, so let's just watch the logo on the plate to see if he moves them at all. Yeah, it's not bad, but look, dude, you're just taking too long between reps. Go, hurt 3, 2, 1, pull. You're thinking about it, you're gonna make it heavier. Yeah, also don't change your gaze position. Pick a spot, look at it. Yeah, none of these are bad. That's not even, I mean, RP 7, 8. Nice job. 331 for a set of 5. Yeah, so lock, I want you to stand up the top of every pull. Yeah, you're just like a little short. Stand up, lock it, wait for the applause. And then I would try to get you to set your lower back just a little flatter. It's just, yeah, it's almost like your hips are like a ½ inch low and it's hard for you to get that last bit of extension. So I'd raise your hips up a ½ inch, really squeeze your low back into extension, and then yeah, just lock them out all like that last one. Sick belt, man. Okay, this is, yeah, 3 weeks ago, 2 weeks ago. It's 573. Fine. That's all I can say. This is 601. This is last week, I believe. Yeah, so I rated this an 8. Moved pretty well. Now we get to watch it in slow-mo. Yeah, so you can watch the feet. So the heels, you don't see the heels come up, you don't see the toes come up, anything like that. Depth is good. Good eyebrow drive. Oh, yeah. This is 190. Yeah, you get to see some bench presses that are overshot. I don't know. I just, I'll show you guys my whole bench setup in some of these videos. But yeah, bench hasn't been feeling the greatest, but I think it's coming around. I think we're turning a corner. So this is 418, 190 kilos. Yeah, pause a little short, and then I punched it a little forward. That's why it kind of slowed down on the way up, but still went. This is 190, a week later, 192 and a half, 425 pounds. Claire is not impressed, but you know, what are you gonna do? Not bench press. You see my whole setup. All right, so just watch, see how the bar path is here. Yeah, the pause was short, and I actually think that's hurting me. So yeah, pause was short. Luckily, this week I had some good benching in, so we'll save that for the next vlog. All right, so this is 180 kilos, 2 count pause bench, overexposed. Yeah, I'll show you guys some more of this bench setup, and we'll talk about it in detail. Yeah, so the idea is that you want to push the bar back off the chest. You can see it on that video pretty well. And now this is 358 for a triple. Yeah, just watch the bar. You want the bar to go back off the chest first. So it's not up and back like in a diagonal, like you're almost scooping it back, that initial movement. Yeah, and this was the next week. So this was last week, I believe. 413, 2 count paused bench, paused. Yep, that might have been better than my comp bench. 170 kilos, 374, more 2 count pause bench. It must be the pink. It must be the pink, you know? Yeah. So again, just right off the chest, shoving it back. This is pretty good. I'm happy with those pauses. Happy with those pauses, all things considered. Okay, so we're just gonna watch this. This is 363 plus 100 some change in chains. Now they don't all come off the floor, so who knows what this is. Probably like 430, 440, something like that at the top. So watch it in slow-mo. And now we'll watch this in slow-mo and go through the steps. So take a grip. Mine's about pinkies on the ring, maybe a little narrower than that. Step 2 is gonna be to take your arch. Now I do this by levering myself against the bar. Now this is mostly in your lumbar spine. People say it's a thoracic thing. No, it's not. Pin your shoulder blades back to the bench. That's active shoulder retraction. Get the lift off. Big breath. And now you're gonna initiate the descent. And then to drive the bar off the chest, you're gonna drive your heels forward, push the bar up and back towards the rack. Rack. Step 10, it's not in here. Profit. So that's my little bench setup. You can watch that again if you like. Close grip bench, pause. Yeah, that was good. You can see the bar go back on that one. This is the week after. Looking thick with 3 C's, bro. This is 185 kilos, 407. Yeah, it's been hot. It's been hot, man. I feel like there's just too much hair, you know? What are you gonna do? Yeah, and you see that scoop back. That was actually a little late, but I'm happy with that considering the weight, and yeah, close grip bench is going well. All right, it's deadlift time. I like that I set up these videos like a powerlifting meet. This is 700. This was 2 weeks ago, I think. Yep, something like that. So 317.5, 700 pounds. People ask me why I do this, like these hip things. I think it's just to get mentally prepared to pull this weight. But yeah, this moved pretty well. Kept it on my legs. I looked at the Ivanko sign, didn't kick it forward. Okay, what is this, 325, 716? I think this is a week ago. All pink, all pink. It's rock. I'm gonna kick it forward, I feel it. There it is, yeah. And all that flex in the bar is off my left leg. I could've lucked it out better. So this is 666. Yeah. That second one's a little forward. I can tell just because it's a little slower off the floor, but the plates aren't moving, so I'm not kicking it anymore. Third one. Hey, good lockout. Look at you. You're capable of it. That's 660 off a deficit. I actually did this after I did my pin squats and a heavy bench press, so kind of had a weird schedule that week, but it was good. More deficit pulls is 550. So you can just look at the Ivanko logo and just see if kick it forward. Yeah, you're pretty good. That's light. So now this is 600. My right knee's caving a little bit. I don't know if my stance is too wide or if I'm just standing awkwardly because of the platform or something. That's all right, still move quickly. All right, what is this, 290? Again, looking at the logos on the plates. Yeah, a little bit. That was a little tucked forward, yeah. That one's better. I guess this actually is heavy, huh? Yeah, third one's the best one. Nice, cool. And then now, what is this, 672? I probably overshot that. Not bad though, not bad. So what I ended up doing on this particular day, I didn't want to overshoot my single. The day before I had pin squatted 585 for one, and that was, I overshot. And so I didn't want to do that again. So I just did my triples all the way up, 3 at 7, 3 at 8, 3 at 9, and then pulled my single afterwards. And so that's how that worked out. The single at 8 probably, was probably higher than that, probably a single at 9, but given the fatigue building up, I was okay with it and accomplished the goals for the day. In any event, it's first training vlog in a while. We got another one dropping next week, then the meet training vlog, and then a bunch of other new content coming up. So hit subscribe so you can stay up to date with all the latest content. Drop us a comment below. I'm gonna read the top comments on the next video. So again, another training vlog dropping next week, then the meet vlog, a bunch of other new content. It's gonna be great. Hope to see you there. Thank you so much for watching. See you next time.
Like, ride with me if you ride with me, you can slide with me if you feel like 550 on the 5 sticky, come get high with me, that's a deal, right? Ride with me if you ride with me, you can slide with me if you feel like 550 on the 5 sticky, come get high with me, that's a deal, right? That's a deal, right? That's a bet, right?